hear me? Yes. I've been told I don't need a microphone. I think that sounds correct, right? Yes. See? And you know the crazy part is I'm a quiet person in real life. But when I need to talk loud, I can do that. So I want to thank everyone for coming today. We have a great event planned for you. I want to welcome everyone. We have attendees representing 24 organizations this morning. I think we should give a round of applause for that. That is always a phenomenal thing. My name is William Hall. I'm in the board chair for the Jordan Health Foundation. They're trying to do phenomenal things, and I'm extremely excited to be a part of this event to get some good information to you all. As part of our mission, the Jordan Health Foundation is tasked with educating the community at large about how the myriad facets of the healthcare industry impact all of us. To that end, the foundation has implemented a series of roundtable discussions that address the dynamic and complex issues inherent in providing healthcare services. Today's topic, the transition from fee-for-service to value-based payments, has been garnering a great deal of interest as the healthcare industry looks for ways to lower costs and at the same time improve outcomes. Right now I want to introduce our panel of experts who represent healthcare providers, payers, and consultants. So first we have Gerald Archibald, Senior Counsel at the Bonadeo Group. I think we're going to give a round of applause for everyone because we appreciate your time. Jennifer Briggs, Chief Operating and Finance Officer, Greater Rochester Independent Practice. Mark Cronin, Chief Operating Officer, Accountable Health Partners. Dr. Janice Hartman, CEO, Jordan Health Foundation. Matthew McKinnon, Vice President, Network Operations, MVP Healthcare. And last but certainly not least, Chris O'Donnell, Vice President, Provider Network, Innovation, Excellis Blue Cross Blue Shield. Now to get started, I'm going to turn it over to Mr. Mark Cronin, who will facilitate the discussion. There will be time at the end of the discussion for Q&A.
Thank you. Very good to see you all this morning. Thank you all for coming. So one of our first questions for you is, can you hear us? We have a microphone up here. We will try to speak loudly or pass the microphone, but please, if you find out you can't hear us, just call out and tell us you can't hear us, and we'll figure out what to do about that. So really good to see you all this morning, a great set of folks from all over the community. And we've got several discussion points we really want to cover here. One is, if we're going to talk about value-based payments, how about we define what it is? What does it mean for patients and providers? What are the benefits of it? How does it cause the healthcare system to look differently or act differently? And I imagine some of you out there are also thinking, well, how do we participate in that? How do we gear up for that? What does that look like for our organization? So we'll try to answer those questions as well. As William said, we'd like this to be interactive. We do have a script of questions that we as a panel have worked on together, so everyone here knows what the questions are and are prepared. But we want to use that as a loose guide for our conversation this morning. So we'll stick with the agenda as it makes sense, but as people have questions or a good topic comes up that we want to drill deeper down into, we'll do that. So want to have a really good interactive session this morning. Hope we end up at 10 o'clock and that it's been informative and interesting for all of you. So does that sound good to everyone? Yes. Can you hear me? Yes. Great. Okay. So if we're going to spend 2 hours talking about value-based payment, it occurs to us we should probably define it. So let's start with that, and I'm going to ask each panelist to quickly define the term. And as a moderator, I'll just start out with my own definition of it. If I look at what value-based payment, what does it mean? I think it's really the payers of healthcare. When we think about who pays for healthcare, it's all of us in this room. All of us are patients in one way or the other. We all pay for it in some capacity. But payers are also, it's insurance carriers, like the two of them that are here with us today. There are large employer groups that pay for their employees' health care. The government is a payer, so there's a lot of payers in health care. And I think there's broad consensus that health care is really expensive, and it's too expensive in the United States compared to other countries. And therefore, we need to do something different rather than you do more and you just get paid more. And I really look at value-based payment as it's the payers of health care who are saying, we want to pay not for just the more you do, the more you get paid. We want to pay for value, fundamentally, that's what I think value-based payment is. So that's one person's opinion, but I want to hear from the rest of the panelists, and I'll just start at the left and work my way down. Chris, good morning.
Good morning. So hopefully you can hear me as well. And I think, Mark, you hit it pretty good. I would say it's a collaboration of payers and providers working together to identify quality goals and metrics, and working to hit those goals. And as Mark said, not paying for more that you do, the more you get paid, but actually trying to drive high quality and better outcomes by looking at an individual in a holistic manner.
Good morning. At MVP, I think you're going to hear a similar theme for this question, but it's really about advancing the value of integrated care. And part of that we'll be discussing this morning is moving away from the fee-for-service to alternative payment models. So at MVP, we really want to partner with the provider as far as what works for them. They know their members. They know the type of members they're serving. So what different type of payment models that are going to move to the high-value care?
Hi, good morning. Value-based payment, Matt mentioned fee-for-service, so probably most of you know what fee-for-service is, but I'm in community health, been community health for 44 years. And fee-for-service, patient come in, whatever you do, you get to bill, you get paid, or depending on the insurance, you get a fraction of the payment for what you bill for. So years ago, they started talking about the AAA. They started talking about better patient experience, better health outcomes at reduced cost. And at the end of the day, for me, that's what value-based payment is saying, that we want the patient to have a better experience. Naturally, we want the population that you're serving to have better health outcomes, and we want to control that cost. And so we'll talk about it later, how that creates some challenges. However, it makes sense. It does make sense.
When I think about value-based payments, I really think about it in the phrase of value-based care, because I think that that's really what the focus is. It's all around the care and bringing together the parties that are responsible for that. So whether it's the provider, or it's the payer, or it's the patient, all coming together and defining what that value is. And I think of value in the same way that I think of it in my personal life. When I'm going on vacation or shopping for a vacation, I want the best possible experience for the right amount of money. And I think we need to equate that when we think about value-based care of I want the highest quality care for these patients at the right price. And all of those parties coming together to figure out a model that makes that work and makes that happen to improve the experience. So that's how I define value-based payments or value-based care.
Sure. I'm the historian at this table. I have my 50th year in public accounting. I started my career at Arthur Andersen, auditing Genesee Hospital in 1973. So my first exposure to managed care was preferred care, which preceded the Blue Choice product. Now, I'm not going to go through the long list of history over the last 50 years, but I think it's important for you to know that value-based payment started out as a different terminology, and that was performance targets or performance metrics. And I think it's interesting for you all to know that we are still, 50 years later, looking at reducing hospital facility utilization, reducing emergency room visits, and trying to find the right site of care at the most cost-effective level. That's one measure, depending upon the optics of how you look at value-based payments. The other measure that you want to be understanding is we're trying to also improve the quality of the services that are being provided to the patient. Sometimes we lose sight of that, the dollars versus the quality, but I do believe that VBP, in all of its iterations over the last 50 years, has been a positive move in the right direction. I wish we were further along than we are today, and I think you'll find out as we discuss it. It is now another focus that we are going to do something more definitive in value-based payment, which affects what Janice just talked about in terms of your fee-for-service revenue. There's a distinction now between we'll pay you fee-for-service, but we're also going to reward you for good performance or penalize you for poor performance. I'm done?
Okay. So Jerry referred to himself as the historian of the panel. When we were putting the panel together, we said he's the expert and the one who has to keep the rest of us honest. know that that's his role as well. So thank you to all the panelists for kicking this off with a definition. So let me shift to a perspective of, okay, now I know what it is. Why should I care about this? Jen, from a provider perspective, why should we care about this?
Yeah, so let me start by framing kind of where my perspective is coming from. So I'm here today representing GRIPA, Greater Rochester Independent Practice Association, and we're the network for Rochester Regional Health, both the employed physicians by Rochester Regional and the facilities there, as well as the independent community physicians who are aligned with Rochester Regional. So that's where my perspective is coming from, and GRIPA works really closely with our providers around value-based care, both in the agreements that we have in place today to ensure that we're successful, as well as preparing for that advancement. Just like Jerry talked about, it's a journey. We've not arrived. We're continuing to progress. So the question of, from the provider perspective, why should we care about this? And I think if we had, a room full of physicians and you asked every single one of them or providers, why would you care about this? Their answer is always going to be about the patient. I want to take care of my patient. I want to do what's right for them. I want to provide the best possible care for my patient. And our healthcare system today, and historically even, has just progressively moved toward less focus around just the care of the patient and a lot more around the administrative parts of medicine. And that has made things inefficient. Healthcare in our country costs a whole lot more. That's one reason we should care about it. Our quality outcomes have not been as successful as other countries. Another reason we should care about it. So that's really why from a provider standpoint the model needs to change, is because we want to get back to the caring of the patient and providing that high quality care at the right cost that also financially rewards the provider for how they're performing that high quality care. So that's the part that excites me. By way of background, I'm a CPA. I started in public accounting. I kind of fell into healthcare, and I love the business side of healthcare, of finding a model that works with our providers for that ultimate goal of caring for the patient. And when it's done right, when all of those interests are aligned within value-based care, that's when that high quality comes in and it rewards both the provider, it helps the patient, and moves us to an outcome that really progresses our healthcare system.
Thanks, Jen. Matt, from a payer's perspective, why should we care about this?
So from a payer perspective, and similar to what Jen added, what's changed for MVP, and I am a former legacy preferred care employee, so I remember the old days of PIP and capitation and so forth, but what has really changed for us is it's no longer meeting with just a Kodak or a Xerox or a Bausch & Lomb to sell a plan. We're getting to the member level, our customer. So your patient is now our individual concern. It's not just selling a group plan. What is specific for this specific member? So then how do we coordinate the member's care with their provider? So we see our role in collaborating with both our member to educate the member to get the best care through their provider. It's no longer, we talk about fee for service, and as a plan, okay, the less the member gets treated, the more money we make. No, it's shifted from, we want the member to be treated, we want primary care services to be delivered to prevent future issues, future high-cost claims. And I think one of the biggest things too, especially today that COVID has taught us, is how healthcare has changed for each different member. So an MVP Gold member, the care that they want to receive is totally different from all my nieces and nephews in their 20s who haven't seen their doctor in 3 years because they do everything on the phone. Telehealth versus wanting to be seen by the physician. So we also have to change to what our members expect for their care. When I talk to my one nephew, Jacob, I'm like, when's the last time? He just picks up his phone. He goes, man, I don't go anymore. I just do it all on my phone. And of course, it blows my mind. I'm much older. And I talk to him about, well, what about your annual visit and things like that? So those are the things that challenge us. But again, from a payer perspective, It is now member-specific. It's no longer the big group organization. We're getting to that level.
Other panelists want to weigh in on this question?
I would love to weigh in
Sure.
because I come from the community boots on the ground perspective. And so I'm looking at how does it impact our patients and how does it impact quality of care is number one with us, patient first. That's been our motto for decades. Value-based have to support that whole person. So it's not just the physical, the blood pressure. It got to support the whole person. So, I'm a dentist for 44 years. And I remember folks say, are you a social worker? Because that person that comes into that chair, recently an 80-year-old woman, and she was apologizing for her smell. I said, I don't smell anything. Her water had been turned off for over a month. At that point, it wasn't a dental appointment she wasn't a medical patient of ours. I'm calling the social worker downstairs. We got to address that. So when you look at value-based, for me, it means you got to support that whole person. And we know that majority of what impacts their health, what helps them get better, are the social needs of that person. And so I'm all on board with value-based, but it has to be a holistic approach.
Thank you. So next question is for Chris. Chris, so do value-based payments, does this change the benefits that a patient has or how one's benefit plan would work?
So I think of that question in kind of two ways, benefits, right? Benefits associated with your health plan and then benefits to the patient themselves. And so the first part, no, they don't change the benefits that somebody would receive from their health plan. Should really not have any impact and they should not see a difference. And the care is being delivered or the benefits that they receive should not have any impact on the way that providers are reimbursed. But the benefit to the patient, I see a big impact there. As Janice just mentioned, and I mentioned earlier, right, value-based is all about a holistic approach. Instead of paying a provider to just take care of something that Chris walks in with, my shoulder hurts, my arm hurts, I have a bad back, whatever it might be, I have diabetes. Instead of treating each and every one of those individually and getting paid to just treat different services, it makes more sense to pay a provider to treat a whole person, do what's needed to help that person be better and to provide higher quality. That's a big benefit, in my opinion, to the patient. When somebody is thinking holistically about an individual versus just a very specific treatment. And the patient will see a difference because a provider will ask different types of questions and dig a little deeper into everything that's going on with an individual, and that's where I think we'll see some real value.
Thank you. Other panelists want to weigh in on this question? Okay, shifting gears slightly. So Dr. Harbin, as a health center, how do value-based payments affect your patients and your providers, and how does that look different than it does under fee-for-service?
I would say, starting off again, the fee-for-service, and we do know that we have urgent care, and we know that a lot of our patients that may come through our urgent care are our patients, but I need this problem solved right now, and then I'll deal with everything later. Value-based, again, I will say, and probably I will repeat, and you'll say, stop repeating that, Janice. But it have to be, as Chris said, the holistic approach. It have to be not only that physical, but understanding those community-based organizations in the community that support that patient. That's part of the health of that patient. So value-based have to support that, so that it's a team working for the good of that person. And the impact, you can see the impact. So you see the impact with all the services that's available almost in that one-stop shop that happens in your systems. You see the difference in that, the support. However, it's a struggle to provide it when it's not compensated for. It's like you must give it, but good luck on how you pay for it.
Other panelists want to weigh in on
That's
this
the
question?
truth. No, it is true. Well, just a quick comment to that, right? Sometimes when people are talking about this type of stuff, it's, I don't know, they use different words, it seems more complicated. I really like to try to think about it in this most simplistic form, right? People do what they're compensated to do. If you pay somebody to do a certain thing, they generally will do a certain thing. Aligning the incentives, value-based payments are all about aligning incentives to do what is needed for an individual. And that's where you really begin to see changes, when somebody is incented to provide holistic type care. I know I keep using the term holistic, but that's really what it's all about. And to provide higher, which will lead to higher quality, better outcomes, and certainly higher satisfaction. To me, that's what value-based payment is all about.
So let me direct this question initially to Jerry. So we've talked a lot about value-based payments and the alignment of incentives, as Chris has said. So have value-based payments replaced fee-for-service?
No, and they, in my opinion, never will. I do think, relative to the comments that have been made so far, one of the key understandings that you need to know is that at the individual patient level, in interacting with a provider, the construct of a value-based payment is not in either one of their minds. It is a population health view of, for a cohort of patients, how are we measuring up to performance statistics in terms of health issues and utilization as well as cost. So my prediction is that right now, unless some of the hospital systems have gone into what are called full capitation arrangements, that is a, if you will, VBP on steroids. But the VBP we're talking about today, which is being emphasized in this Medicaid waiver, I believe will ultimately, approximately 3 to 10% of an individual provider's revenue could be impacted by, hopefully positively, by the improved performance and the improved patient outcomes that come from all the data analytics that the insurance companies are applying in their VBP contracting. So it's not a wholesale change, although health systems have the resources, the size, and the patient population to be able to do far more in terms of risk associated with reward, and that was the capitation comment that was made earlier. What we're trying to focus on today is at the, if you will, community-based organization level. VBP is between 3 and 10%, and for the next 10 years, it's probably going to be 3 to 5.
So Jerry's made a couple interesting comments there, saying that in his perspective, it never will completely replace fee-for-service, and he put out the figures 3 to 10% of a provider's revenue. I'd be interested to hear other panelists' perspective on this question.
I mean, I agree with Jerry. I think today we're at MVP, we're right around the 5 to 6%, but I do agree until we get to any type of full risk total capitation, fee-for-service will be in play for many years to come.
And I just want to add, Jerry knows I basically always agree with Jerry.
And I appreciate that very much.
You're quite welcome. But when you talk about risk, he also brought up the community-based organization, the boots on the ground, the community health. It's impossible that they ever would get to the point that they can fully 100% say we're at risk. We see patients regardless of their ability to pay, whether they have insurance or no insurance. If they need medication, we're making sure they get the medication. So you would never be in a position They need peer counselors that you can't get compensated for. They may need community health workers, can't get compensated for. They need social workers, some you can get compensated for, the majority you can, but they need that support. So community organization, community-based organization will never get to the point that they could say 100%, I'm going to get this person to this position and then don't pay me unless, so don't give me incentives unless you get there. Again, I have to bring up those social needs of that patient. All of that have to be in play and supported if we're really going to improve the health of this population.
Other panels?
Yeah, I'll definitely say, fee-for-service has not gone away. It's still the primary world that our providers live in. But it is a transition, and I think we need to think of it as a journey and a transition, because it's not going to happen overnight. It's not going to be a light switch that just all of a sudden turns on, that you magically move from one world to the other. It is going to be a transition and a balance of, learning these new concepts around value-based care and what truly matters in that model, and transitioning over time toward that, and not completely replacing fee-for-service in that process. So a lot to learn, a lot to journey through.
Mark, just to... Sure.
Are we allowed to ask a question? Is there, how does this go? Are we just going to listen, or do we get an opportunity to ask and pose questions to your panel?
There shall be no questions in the audience.
School board meeting. I didn't know the itinerary.
We will be better than that.
Mark, I just didn't know the itinerary, whether there was going to be a question.
Please.
So I'm Jeff Allen. I work with GRIPA, and I've worked with many of you in meetings virtually. But my question is, and my focus, and a big part of my job is preserving the primary care provider, preserving the primary care physician. If any of you have tried to get a primary care doctor or friends or relatives, pretty darn hard. And I think that primary care doctor is critical to this whole process of value-based care. You've all outlined holistic care, Dr. Harbin, Chris, talking about holistic care. Who do you think of providing holistic care? Primary care physician, right? They know you, they know your family, they know your meds, and they also know how to get you to the right specialist, which I think is sort of drives away from what we're talking about, this holistic care. It certainly, I'm a primary care doctor. It elevates costs. If you're using primary the subspecialists more, they're going to do procedures. They get paid for fees. They get paid for doing these high-cost services. And we need to preserve our primary care physicians. I'm all about value. They're all about value, right? That whole value equation of cost and quality. They can help sift through some of the complicated decisions that you face when you're facing your medical problems. So my question to you as a panel is, how do we preserve our primary care base? We are losing our primary care base. We're trying to become innovative in how to use, certainly APPs, which is great, but we still don't have enough. It's insufficient. And I would like to have you think about how we're going to preserve that population of providers, who I think are critical, and utilize value-based care in that setting.
Appreciate the question, Jeff. Jerry, you want to take that?
Mark. Great question. For 50 years, I've been a supporter of the physician community with particular emphasis on primary care dating back to the days of RECIPA, which preceded GRIPA and AHP. We have our son as a third-year fellow in oncology at the U of R. He's not even in practice at this point, still getting paid what you would as a fellow, which is the slave wage. He has gotten 5 emails unsolicited from around New York State offering him $500,000 a year to go into oncology hematology for a 4-day work week. Our daughter, nurse practitioner in Boston at Mass General, and most primary care physicians are, I would say you could agree, roughly half of that, somewhere in the 2s. Some of them can be higher in terms of salary, but until we create fair balance with respect to reimbursement and compensation, The primary care physician, as I knew them, as I've been growing up for 70 years, is gone to be replaced by nurse practitioners and PAs. And that, to me, is a sin with respect to what the U.S. should be able to do as it relates to healthcare and how healthcare is delivered. Because I will tell you that my daughter, as a nurse practitioner, is not as knowledgeable as a primary care physician, because I just saw my son go through medical school at the U of R, residency at the Mayo Clinic. They're not the same. It's not the same.
No, and I'll chime in as well. I certainly agree with what Jerry said. I think of the comment Chris made a few minutes ago when he talked about people tend to do what they're being compensated for. In this case, if you're going through all the time in schooling years ago into a medical education, and one career track is going to pay you X and another career track is going to pay you 3X, guess what? A lot of people are going to choose 3X. I think, to me, one of the main message points I take out of Dr. Allen's question is, I think it's important people to realize there is a primary care crisis in this country, and there's a primary care crisis locally, and it's going to get worse before it gets better, and I'm not quite sure what the path to it getting better is. And I think part of it has got to be the compensation for primary care physicians. Others want to comment, Matt?
From a payer's perspective, and Dr. Allen, I agree with your comments and concerns. The bulk of our payment models are based on where the member is attributed to. And 90% of that is to primary care. We are being challenged as a plan, and just over the last month, we're looking at this attribution, because we are finding members are now treating their specialists for certain conditions. They're treating their specialists as their primary care. And you can understand that if you have a cancer diagnosis, if you're going through a certain episode of care, we also now have to look at the specialist beyond primary care. We're surprised that it's changing, but we have seen the shift that this is brand new to us, that we've been monitoring just over the last 8 weeks. That we're seeing, again, more members, again, based on condition, who their primary care is.
Attributed, yeah. I mean, primary care providers are the heart of the healthcare system, in my opinion. And I think most people at Excels would agree with me on that. They are the ones that should be directing the care. If you think about it, if anyone's going to think about the whole person, it's the primary care provider who's going to do that. I agree. I'm with Mark. I don't know what the answer is and how we do that. I think compensation is a huge part that needs to be figured out. It's a really difficult problem. I think it's going to get worse before it gets better. I think we've had a problem for years, and it's just continuing to erode. And I think that's something that we do need to work on.
I agree. That, again, I keep going back to what I know, community health. We have been fortunate to have primary physicians come in, family medicine, different internal physicians come in. I know that for years there's been support of exposure, getting these folks early on in medical school, that their rotations is in community clinics, so that some people come. So we know that probably the majority of the folks that service our patients have a heart for what they're doing, because Lord knows we can't pay them really for what they're doing, but they have a passion. And how do you expose more people to what they could have a passion for? But you do need to compensate, because at the end of the day, the cost of even going through medical school is so great that you have to support that. And you can imagine it's very difficult if you're a community health center, because now you're competing with these billion-dollar health systems, but you're competing against billion-dollar health systems. How do you do that? Because the goalpost keeps moving. If the goalpost keeps moving, you keep trying to chase it. It's only so far you can chase it, because the money is just not there. But great point that you brought up, Doc.
I would just finally say that My solution, which will never happen in my lifetime, is you gotta get the AMA, the feds, and the state together to create some mechanism for, if you will, fixing the imbalance of compensation. I had a dozen discussions with my son Bill about being a primary care doc. I'm paying the tuition, deferred to by Janice. He said, Dad, that's not the quality of life I want, and I can't make anywhere near what I can make by going into a specialty. So until we reverse that, I think your issue is one that is going to be a very difficult one to crack or solve.
And Jerry is our self-appointed historian. I remember in the late 90s, some folks who remember have been around a while, RVRVS, resource-based relative value scale. That was supposed to be a significant answer to this issue.
Thank you for reminding me, I forgot about that.
And still here we are.
Yeah, that was supposed to shift from the specialist reimbursement and put more money into primary care.
Jerry, I'm only smiling because some of you know I am a dentist. But I'm a public health dentist, community health dentist, the whole 44. My son, he's like, that's not the lifestyle. He's an orthodontist. He said, Mom, I'm gonna have to take care of you. So he would even consider community health. He's an orthodontist. He's a specialist. Because I went to school. I want to have a lifestyle that contributes to that. So.
That's my question in the middle of the room. Yes, sir. Oh.
Sir, my name is Chris Lavin. I'm the executive director of the Boys and Girls Club in Geneva. And we've been taking a different approach in Geneva to truly holistic care that Janice was talking about, where we start with infants, prenatal, no income-based thing. We improve daily gym time for the parents, breakfast, food, diapers. We have a deal with the Mormon Church of Utah to give free diapers to all babies in Geneva. But one of the things we're finding is we're trying to build this holistic, family-based center of support is that the getting the social service agencies to adjust their methods to get better access to these families, to all the families in Geneva. The medical industry is a little bit more opaque to us. They cling to the hospital clinic form, you come to us kind of model, and ART is open to the innovation and change that I think would give them access to many more families. I have 2,100 families, access to them with insurance. Getting the medical industry to come out of its routines seems to be difficult. And I don't have the expertise to say that those routines are standing in the way. But it seems to be when you talk about holistic care and the importance of a physician, the untapped, unaccessed families that are numerous and remain numerous aren't coming into that equation. At least in my experience, as I look for partners in the medical industry to come in and take advantage of the holistic approach we've taken in town. Geneva's a little Rochester. It's got all the diversity and poverty and everything else, but gives you a little bit more of an avenue in on how we might do it differently. I don't find the medical industry to be as open, or the doctors willing to get out of their offices with more speed to access more families.
If I may, before others respond again, I look at healthcare through a different lens, since I'm an accountant and a bean counter, but I'm also a patient. What you just described is absolutely fantastic. And what we are trying to do in the most recent iteration of integration of healthcare is to draw in what you've just described as community-based supports. You refer to them as social supports. We love using acronyms in healthcare. Just remember these two. Social determinant of health, SDH, and you now have health-related social needs, HRSN. Same thing, different terminology, I shouldn't say same, almost the same. But we have a tremendous issue in terms of being able to reach out to the Boys and Girls Club in Geneva. And I've spent 40 years of my career at Geneva General Hospital and other clients there. And I couldn't agree with you more that the walls and the silos that exist between hospitals, physicians, social determinant health providers, and also behavioral health, which we've been working on for the last 50 years. What you just described is the message of what we're trying to do now, which we've tried to do before. We've made progress, but as Jen said, it's a journey. We're not there yet. And I'd say we got a long way to go. It'll be after I die, let me tell you.
I hope that's not true. But let me piggyback on Jerry's comment and the good question we got here. So Jerry talked about social determinants of health. And already in the questions we had so far with the panelists, I think Janice has mentioned CBOs 2 or 3 times, and at least one other panelist did. So how do CBOs fit into value-based payment and working with the healthcare system? So I'd be interested in the panelist's perspective on that.
Well, I'll start off. I mean, I think the 1115 waiver that I'm sure most everybody here is familiar with, that the state is currently negotiating with CMS. I think that's a really good start. I think incorporating those social determinants of health into value-based payments makes a lot of sense, right? It's kind of closing that gap. It's identifying that things like food insecurity, transportation, safety, those types of things, housing, have a huge impact on somebody's health, somebody's medical outcomes, and incorporating that into value-based payments will help close that gap. And so I'm really interested in that. I'm really interested in seeing how that plays out, because I think that can be a model and certainly bring us to the next level. Just one other thing, I wanted to make a comment earlier. We talked about the transition when fee-for-service, is value-based going to replace fee-for-service? And what I will tell you from my perspective is that we are in the very early stages of value-based payment. I was mentioning to Matt, I went to a conference a couple weeks ago, and there was folks represented from the entire country, and some of the very basic questions and comments that were being talked about really make me believe that in Rochester, New York, we're pretty advanced for value-based payment, which surprised me, to be quite honest. I didn't think that we would, be one of the leaders, but we are one of the leaders in the country. But even saying that, I will say that we're still in the very early stages of figuring this out. This will be iterative, and we have to keep on pushing at the edges of how do we get more people covered, how do we bring in those social determinants of health, and we have to be creative to how do we make sure that we continue to have a large enough supply of primary care physicians. All of these types of things we have to keep on discussing and dialoguing. And I think that's one of the great things about a panel like this and a room full of experts like all of you, is that we do have these conversations in Rochester, New York. And I think that is what's helping us be one of the leaders in the country. But we have a lot more work to do to really make it be as good as it can be.
Thanks, Chris. Other panelists, John?
One quick comment, from the provider perspective. So this is where I think that providers have always known those social determinants of health. They influence the health of their patients. It's been the business model that's been lacking of connecting the two, and that's really where the strides forward are just starting. I mean, really just starting, is trying to have those incentives aligned. So like your example of the Boys and Girls Club in Geneva, of making a financial model that connects that to make all those parties come to the table to make it be financially successful and viable on both sides that benefit those patients. So it's exciting to me because I do think that is a new connection that is being forged, but there's a long way to go in making those connections to make it work.
And I will say, for the first time, going back to what Chris and Jen have said, for the first time, the 1115 Medicaid waiver that is hopefully going to be approved somewhere this summer, which involves billions of dollars, has a carve-out for doing what Jen just said. There's a specific amount of money in the application that's devoted to integrating social determinants of health, community-based organizations, HRSNs, whatever you want to call yourself, with the traditional health care that people receive through the hospitals and physicians.
Joanne Ryan, I see you have a question.
Joanne Ryan, President CEO of McDonald House, Rochester. Thank you very much for your views. Just more a comment than a question, but really I think it dovetails into what was just being said. The challenge now, we know that providers, Dr. Allen well said, are head down delivering important care, and they don't have the bandwidth for the social service supports that we're all providing, those of us that are in the community-based space. The challenge around that right now, though, is how do you discern which part of that value statement actually applies to community-based organizations? It's very easy to say, this is the touch that saved that life. But when that life went home and we support them in a discharged state, where's the value and how does that get recognized? That's a concerning conversations that we're having. We know we are contributing to patient outcomes. We know we are decreasing costs and increasing value. The challenge is how does that equation look when it comes to reimbursing the services that now are being philanthropically supported by almost 100%?
Thank you. Anyone on the panel?
I want to comment, well said. When we look at the support that's needed, when we look at even cultural competency and hiring from the community and training those that people relate to, therefore they're going to listen a little bit more too. They're taking the message of the provider, however, it's coming from someone that I can relate to and I can trust. You look at the peer counselors that's needed. If I've been through this, I have a better chance of talking to you that's going through to say, hey, I can help you navigate this. And so again, as we talk about the business sense, it makes good business sense to begin to support those entities in community-based organizations that right now cannot get compensated for. If we're serious about improving their health, we got to look at every piece of that and say, we have to support it. Because when that person go home, we just had a press conference about doulas and the impact of doulas. And again, but you gotta support that, because at the end of the day, you're making a difference in the health of that community, not only that person, that family, but of that community. So thank you for bringing that up, Joanne.
And I will just add to what Janice has said, to your point, Joanne, carving up the dollars in healthcare fairly is as complicated as the federal government trying to come up with a budget.
Well, that makes us all feel hopeless.
Well, I am known to be a little bit of a pessimist.
So we've talked a lot about value.
Chris, you got a
Oh, I'm
question
sorry, I
over
missed it.
My name is Charmaine Jeter. I'm with the National Witness Project, and I guess a lot of people say, well, what is the National Witness Project? I think we come in hopefully before it gets to everybody else. We educate. We make people feel comfortable because we have seen what is happening in our community with African American women concerning breast cancer issues. How we are getting breast cancer, just like our counterparts, but we're more likely to have fatalities. And it comes a lot from because there is not a trust in our healthcare system. And I'm not saying that there shouldn't be, but it has been proven in our community, it has not really worked sometimes in our behalf. So there's a great mistrust. So there are community organizations like the National Witness Project that goes, and I like that saying, we say it all the time, boots on the ground. Where we go into these communities, if we're waiting for them to come to us, it may not happen to healthcare providers first. We go to them. We have to offer them sometimes incentives just to get their mammogram. If you get your mammogram, we're going to give you a gift card. Because there's the other key word, passion. Sometimes, you have to have a passion to do these. And if we can educate, if we can get them to trust, then we can get them to get a healthcare provider. We can get them to do the other things that will cause them to go to the doctor, to get their checkups. So it's not only breast cancer we do the cervical. We make sure that they get the colonoscopies, educate them. And it comes from them trusting us. We put a trust base. And if we have to use, we got an organization called FLOW, First Ladies of Western New York. If we have to use their pastors' wives, if we have to use their pastors, that they trust in their church to do these presentations and these educational seminars. We're doing that, but you gotta have a passion and you gotta be willing to do the boots on the ground first in order for them to do the next steps.
Thank you. Couldn't agree more. Anyone on the panel want to comment?
I would just, you prompted me to say, Chris O'Donnell remembers this. I did a panel about 7 or 8 years ago, and I asked the CFO at Blue Cross what the biggest challenge was for Excellus, and Dorothy, right?
Yeah.
Dorothy's response was personal accountability. And we do have a problem in this country with personal accountability, and as a result of that, we do need the supports that you just described, but it's not just the folks that you are supporting, it's almost the entire nation. Taking responsibility for being proactive in terms of what they are looking to get.
Thank you. Mark, did you have a question?
I do. I spent 35 years in the medical side, especially home care, and now I'm on the behavioral health side. How do behavioral health agencies, especially independent behavioral health agencies in the community, participate in value-based payment in these contracts? Covered lives, all that kind of stuff being a major issue. We're a new agency, we have 1,200 clients at the moment, but at what point does it work for us to come, and what structures and what lessons has the medical learned that behavioral health can learn from?
Can I take it? Okay. I want to protect my friends on the insurance side here. They have been told.
Don't protect.
They have been told to not directly contract in value-based payment arrangements with behavioral health networks up until now. I think that's going to change. Everything, as I think Matt might have said, is primary care attribution. What this next waiver will allow, at least in the Medicaid population, will allow behavioral health providers to link in networks with primary care providers and be able to avail themselves of the opportunities associated with value-based payments. You know, we've got a crisis in mental health, opioids, et cetera, et cetera. I happen to believe that the behavioral health providers have a significant benefit to derive from value-based payment, as well as provide significant benefit to the individuals that are going to have better outcomes. So we're not there yet, as we've said several times here, but we're moving in that direction. So now that I've protected the insurance folks, I would like to have one of them respond to you as well.
As moderator, I need to provide equal time.
Yeah, it actually goes to one of the next questions Mark was going to ask the panel. It talks about what are the different alternative payment models. And as Jerry says, behavioral health is something new for the payers. And so there's the different levels. So I'm going to talk a little bit about the different levels. And for behavioral health, we are looking at what we call, pay for performance, where a lot of the value-based started. So with behavioral health agencies, we can look at what is, a PMPM to coordinate care, making sure there's follow-up visits, making sure that there's an appointment within a week after a hospitalization and things like that. So those are the things, to Dr. Janice's point, behavioral health agencies not going to come to MVP or Excellus and say, we want full risk. But what are the different payment models? So Mark, if it's okay, I'm just going to run through a few of the examples.
Sure.
So the different levels, again, starts with, pay for performance. There's innovation funding, which talks about improving patient access and satisfaction. We have shared savings arrangements with, for example, what MVP has with GRIPA and AHP. Then there's progressive risk sharing. How are you going to beat a targeted medical expense? Then it does get into what Jerry was saying, that we're hoping we move to quicker on capitation, bundled payments, and then the full risk, or what we call total global capitation. And going back to one of Dr. Janice's original comments, we look at it now as what we call a quadruple aim, which talks about enhancing the patient experience, how we're going to improve population health, reduce the cost of care, and then drive provider satisfaction. And then one other thing I just wanted to talk about on the last subject. One of my coworkers, Allison Morrison, is sitting in the corner. Wave, Allison. So a couple of years ago, MVP, we started a clinical prevention program that focuses on provider engagement. So we don't just work with the provider and say, okay, here's a program that's going to work for you. because talking about the holistic care, this provider engagement team now works with that provider, our partner, to say what's working, what's not working, what are the obstacles, and Allison and her team will talk about how do we get members to your office, how do we make sure that there's food on the table. Just yesterday I was in a meeting with a provider that wants to open up a clinic in Albany, and it's in an area where there's not health care, and we're looking to see ways to bring other organizations help funding to open this clinic. So this program that we started a couple years ago that Allison is on is making sure all these different levels, whether it's just pay for performance or moving to full capitation, they're successful in answering a lot of those challenging parts besides just the delivery of healthcare.
Thanks, Matt. Chris, would you add?
Yeah, no, I think, Matt covered it very well. I think Excellus has a similar program, where we have folks working with our partner organizations. But at the end of the day, I think it really comes down to working very closely with the GRIPAs, the AHPs of the world, and partnering together to identify where there's opportunities. The behavioral health component is incredibly important. To Jerry's point, I think that the waiver is going to help unlock some of the roadblocks that have been in place in the past. I mentioned it earlier, but it's worth repeating, right? I'm really looking forward to the waiver coming into play, because I think it's going to teach us how to do things differently than we've done in the past. Behavioral health has just been overlooked for so long. Value-based payments are about, again, treating the entire person. Behavioral health is such an important part of that. We have to find more ways of connecting that into the care that folks are getting.
Dr. Herbert, you want to comment?
Yeah, I do want to comment. Thank you for bringing that up about behavior health. I would be remiss not to say I'm on the board of FLIPA, so Finger Lakes IPA, and we were community federal qualified health centers that came together, but understood that behavior health organizations had to be part of that group, that we're seeing the same patients, and we have to work in concert with each other if indeed a lot of those ED visits are mental health, behavior health visits. So you have to work in concert with each other. And I think that I've been following the 1115 waiver. I'm immediate past chair of Common Ground Health, and we know what the data has showed regionally about brown communities and black communities. But again, if the waiver never happens, I'm an old community organizer, so I got to do some good agitation. If the waiver never happens, I think that the MCOs have to look at what do we need to do in spite of a waiver, if it comes or don't come, that behavioral health is a major part of keeping the person healthy, and that mental health or behavioral health, it could be I can't pay my rent, I'm getting ready to get evicted. That's a stress factor for me. That might be a factor that, heck, I can't function, I can't operate because these things are going on. So my encouragement is ideally and hopefully that CMS will see that it makes sense for what New York State is asking for. But even if it doesn't, behavior health can no longer be allowed to be outside the extra factor. It is an integral part of a healthy person. And somehow they need to figure out how that you bring those two together so that it's compensated for, that you can get those peer counselors that actually can work with folks and talk with folks and get them to show up for visits. And so that's my good agitation.
Thank you for that.
Yeah.
Jen?
And I couldn't agree more with what you just said about making sure that that behavioral health component is included in there. So in our value-based agreements today, where the attribution may be derived off the primary care, we know that addressing the behavioral health concerns is absolutely a necessity in order to be successful. We have to include that. If we're looking at managing costs of this group of patients and without addressing that, we're not going to be successful. And the side of making sure that the compensation can work for those two sides to work together has a long way to go. And it is absolutely going to be critical that that becomes a part of it, not only in the 1115 waiver, which is mainly focused on the Medicaid population, which is absolutely critical, but in our other populations as well. We have to look at that whole person, and it includes behavioral health, and that has to be a component.
Thanks, Jen. And apropos of this whole discussion, one of the questions that was submitted from the audience in advance was actually from Dr. George Nazareth here in the front. And George, your question was, are there any best practice value-based payment models that integrate behavioral health and social drivers of health? Is there anything you'd add to that question before I ask the panelists to talk further?
No, thanks, Mark. I just wanted to make a comment that this behavioral health integration question also relates to the comment by Dr. Allen around primary care, because the issue with primary care is not just compensation, in my opinion. It's also everything that's being dumped on primary care to solve the whole problem of whole person care. And primary care today are it's not fair to expect that primary care is going to solve this whole issue. In my opinion, building a team-based care around the primary care practice is part of the solution as well. And behavioral health is part of that. Also, I just want to make a comment that there is an evidence-based model for integrating behavioral health in primary care that we all, I'm sure, have heard about or know, and that's the collaborative care model. And that New York State has designed a model to compensate for this collaborative care model, Medicare as well, but still that's a very difficult process, and there are certain states like Alaska, for example, who have decided to just get rid of the compensation altogether and do a capitated model around collaborative care. So talking about a total capitation is one thing, but there are pockets of capitation that we can look at to compensate certain areas for integration that we can maybe work together and figure out how to make that work and decrease costs and open the door to, in this case, behavioral health integration, and maybe support our primary care colleagues, because it would be, in my opinion, it's not the whole answer to say it's just a compensation issue, although that's a part of it. Thank you.
Thank you, Dr. Minister. Any further comments from the panel?
How about just completely agree?
Amen to that. So, Chris, next question is we'll start with you. So, everything we've been talking about for the past hour or so seems like a lot of work. Why do you think, from a payer perspective, why is it important to move to value-based payments?
Yeah, it is a lot of work. And like I said earlier, I think we're in the very early stages of the evolution. But it's worth it because compensating providers to provide the quality of care versus compensating providers to provide a quantity of care are very different things. I think the quality piece is something, that I was going to say that's been lacking. It's not been lacking, right? Providers always want to provide high quality care. But it goes back to what we talked about earlier. They've been incented to provide quantity of care. And so it is worth it if we're truly going to change the way healthcare is delivered and the results that we get from that. We have to be innovative. Let's face it, right? If we were to start today, I use this analogy a lot, but it makes sense in my head. If we were to start, and just with a whiteboard and design the way healthcare is financed and paid for and delivered today, would we draw it up the way it currently is? Not a chance, right? We would design it completely different. So to continue to do it and try to make improvements on the margins doesn't make a lot of sense. We have to be creative and find new and innovative ways of aligning incentives to make sure that we get the outcomes that we truly want. I think value-based payment is worth that, and I think the investment of time and energy and resources is going to prove to really be beneficial in the long run.
Thanks,
And
Chris.
and if I might just add, everybody's got one of these, I think. We have to understand that there's going to be more and more disruptors as it relates to what we've experienced over the last 50 years of my life. And I believe artificial intelligence, some of the things that are coming out right now as it relates to using AI in healthcare, there will be more than one disruptor that will occur that will change the face of what we would have expected to say back in the 80s before we had Steve Jobs come up with the iPhone.
Other comments from the panel on this question? You got a question out there? Yes, sir.
Next topic, though.
Sure.
So I have two things. Help me remember to come back to my second. My first, so Chris Hildebrand, Executive Director of the Rochester Spinal Association, Disability Advocate, noted troublemaker. I guess my question kind of is the how. You know, so stories. Like, I work with people with spinal cord injury. We're a fairly small community, but we're really expensive when things go poorly. You know, a stage 4 pressure sore, last time I saw, it's something like $250,000 for one, course of treatment around a pressure sore. 95% of them are preventable. Rochester has a lot of good spinal cord injury docs. Let's imagine a future where we have a lot of good primary care docs. It doesn't damn well matter if you can't get out of your house. So the social determinants are great. We're going to address social determinants. How? I work now with a lot of guys and women who were shot and paralyzed. So coming out of poverty, coming out of little literacy, much less health literacy, expected to understand all these terms we throw at them. Peer support's amazing. How do we really fund that? Getting out of your house, living in city housing. I have paraplegics who are homeless, paraplegics that are in shelters, paraplegics that are couch surfing. They can't go to their doctor because they don't know where they're going to sleep tonight. They don't know how they're going to get out of their house. You can't go if you don't have transportation. So none of the best care in the world doesn't matter if you can't get there. So there's the how are we really going to address those social determinants. I would also say, when are these big powerful organizations really going to become lobbyists for the people they serve instead of just lobbyists for themselves? That we can throw money at making one house more accessible, but how about we stop building houses with stairs? So how do we do this, I guess, is the question for the panel. And before I forget, my second part is sort of where's the opportunity for debureaucratizing some things? To the things that I understand, wheelchairs. I could, buy a tire online for pretty cheap. I could have the bike shop or a buddy replace it. I can do that pretty cheap, but if I go through the DME provider, oh my God, $75 or something like that. One of my friends just had to change out the bearings in his front caster. The DME company was going to charge him something like $15 for the part and $30 for the labor. It's a part that you can buy a dozen of them online for like $5, and if you know what you're doing, you can change that out. So I think, where's the opportunity to debureaucratize? My answer might be partially enabling consumers to sort of control the expenses, compensating them. Maybe the person, if they can save some money but still get good care, could be partially compensated. How and that.
Okay. Chris, appreciate the question.
Yeah, very nice.
How? Panelists.
Well, I'll be a little controversial here. You said you're a noted troublemaker. I've been known to be the same.
Now, your job is historian, not troublemaker.
In my career, I've been to 5 other countries, Russia, France, England, Canada, and Cuba, studying their healthcare system, all of which are national health programs. Right now in the U.S., nobody wants to admit it, but when you get Medicare, Medicaid, and Obamacare together, you're talking about 60 to 70% of the population. So what happens in the national, if you will, socialized medicine arena is that you do have the ability to be more consistent in terms of policy. So for example, in the UK, if you're over the age of 80, they've got a structure that dictates whether or not the government's going to pay for a hip replacement. Oh my God, no! You can probably tell I'm a Democratic liberal here. So I want to say that in every one of those 5 countries, there's what you could refer to as a black market. Wealthy people need what they need. There's always a way to get there. When I was in the UK, just real quick, high-level VP at the National Health Service. Wife had to get a cataract, couldn't drive, couldn't see. And he thought he could jump the queue, which is what they talk about over there for their waiting lists. And one of the best benefits is people die while they're in the queue in terms of cost. This is rather, I'm telling you the way it is. And he couldn't jump the queue. They had to go the black market route in order to get, it was an 18-month wait for cataract surgery.
Other panelists?
I think just recognition of the fact that the points that you bring up are real, and those are challenges that people in our community face. And trying to find a solution that does meet those needs as integrated into our healthcare system is challenging. It absolutely is. And it's something that needs to be addressed as we move forward. So great recognition, a great way to be a troublemaker in bringing those forward, because those are real concerns and things that are not addressed right now easily through our healthcare system. I loved your point about fixing the wheelchair, about the inexpensive parts, but man, yeah, you're right. If you go through a DME provider, you're going to pay a tremendous amount more. And so trying to work through those challenges, yeah, absolutely, good points.
So where is that dialogue? I'm sorry, Dr. Harper, go ahead.
Yeah, I would just, Chris, I love it. I just wanted to add, the other Chris here mentioned the word we. We said, well, how are you going to do this value-based payment? He said, we. And what I hope is it's a true we. So folks like Chris, you gotta it can't just be the business people trying to figure out how this is gonna happen. You gotta bring in real people with real problems to be part of the discussion, that whiteboard that you're gonna draw up and say, how do we solve this problem? How do we make this happen? They have to be a true we, so that the folks that lives and impacts has some say in the discussion. Otherwise, it's the business model. And the business model always leans towards the business owner.
One final comment I'd make to Chris's questions, and I see we've got another question in the back, is part of your comments, Chris, I heard them, was about the health systems and healthcare organizations locally advocating for patients. And one of the things I would say, and I feel this very strongly and fervently, is this community is very well served in that we're in a unique position in that the 2 largest health systems in this community, our friends at Rochester Regional Health, the University of Rochester Medical Center, are local, nonprofit, locally led organizations. The 2 predominant payers in this area, MVP, Excellus, are both located or headquartered here in Rochester, the other with significant presence here in Rochester. They are upstate New York, they are local, they are nonprofit, they're doing their best for the community. And I say that not gratuitously, I say that because I believe it to be true, and it's also unique in this community. That's not the case in a lot of other communities, and I think this community is tremendously well served by that situation. We've got a lot of CBOs, representatives of community-based organizations here in the community, so I feel like we've got the spirit and the will in this community figured out, and we've got a situation that's unlike what I see in most of the rest of the country, so I think that's a big advantage we have. And perhaps a good transition, because I see Jamie Saunders in the back, and Jamie, you have a question.
Good morning, everybody. Jamie Saunders, United Way of Greater Rochester and the Finger Lakes. I wanted to thank Dr. Harbin and your team for hosting this incredible conversation. And my colleague here, Dr. Ashley Campbell, and I, as we sit in the back here taking notes, wanted to build off of Chris's great comments and several of our CBO partners. This is a really incredible moment in time to get this right. So to rethink about how we can, with healthcare and social care, which is a new term for many of us in the human service space, but to be part of this conversation to do better and to do right. I wanted to acknowledge that it is this moment in time, but there's so many challenges because in the nonprofit space, we are a sector, but we aren't as organized and coordinated as other sectors. And a lot of that has to do, as the panelists said, because of the dollars, because of the funding streams, because of how those organizations were created. So my overarching question is, to Chris's point, how do we as community-based organizations participate in the dialogue to help shape this so it's not being done to individuals or to the nonprofit sector, but how can we really help contribute to the creation of what can be and building on the incredible assets? Our nonprofits are often described as, again, really filled with heart and grit and moving outcomes and the critical roles we play. We have trusted front doors. And what keeps us up at night at United Way is that this may end up being the survival of the biggest, which do really incredible work, our amazing human service partners. But think of the wonderful stories that we hear about boots on the ground, trusted front doors, what Jordan makes happen. We want to make sure we get this right and that we have the right voices and the right minds at the table. And I'm curious about how you would advise us to ensure that that happens. So this is a true win-win-win of how we can lift the community with equity, with access, and human-centered right in the middle.
So well said. And I wish I had all the answers. And I don't, and I'm not sure that any of us up here, as we sit here, have all of the answers. But one thing I would say, and it kind of goes back to also what Chris said, right, is we got to keep doing more of this. We got to continue to have these kind of dialogues and these types of conversations because community-based organizations are an integral part of taking care of that holistic person. We have to find more ways of incorporating those organizations, whether it's people with spinal injuries or it's behavioral health or it's whatever it might be. We have to continue to incorporate that. We have to begin to incorporate that into everything that we're doing. And value-based payments can and will be a part of that solution. It's not easy. We got to continue to, people got to continue to speak up. I couldn't agree more with what Mark said. And Mark and I don't always agree on everything.
As I say, I've known him for 25 years. I've never heard him say that.
Yeah, it's actually painful to say it, but Mark is 100% right. What we have here in the Rochester area, particularly the Rochester area, upstate New York, but particularly Rochester, where we have organizations that are committed to the community, that's the way we're going to solve these problems. It's not going to be solved by some big national company coming in and telling us all how to do it. That won't work. It's not sustainable. But community-based organizations that are focused on our community will be able to continue, and having dialogues like this, that's the way we're going to find the solutions.
So if I could add on to Chris's answer, just give an example, wearing my hat as the COO of Accountable Health Partners. So to me, it seems that I think population health and value-based payment is a perfect umbrella to create these relationships as Jamie's describing in her question. So let me give one example, and I'm sure my colleague Jen from GRIPA would also have other similar examples. So AHP is part of our contracting. We contract with Matt and with Chris for covered lives under Excelis and MVP, and we have a responsibility to Excelis and to MVP to manage those lives, contain costs, improve quality. And so part of how we do that is create relationships with community-based organizations. So I think most folks know Anne-Marie Cook, and I know she was signed up to be here today from Lifespan, but I think she's not here. So as one example, Lifespan has some very impressive and good care management services. And we connected with Lifespan several years ago and concluded that even though we at AHP also have a nice suite of care management services, what Lifespan has supplemented and we thought did something different and better than we were doing. So we've been contracting with Lifespan for several years. When I say we've been contracting, I mean literally we take some of the dollars that we get from Excelis and MVP and we pay it out to Lifespan, in order to take care of that set of our patients that we thought needed services that they're providing. So I've described it in a simplistic form, and there's a couple other relationships we have that are like that, but to me, that can serve as a template. Again, I'm sure Jen, similar things for GRIPA.
Yeah, absolutely. Partnering with those CBOs that have that relationship and access really augment the services that we provide. I mean, that's how we connect with those patients. Just like Mark said, they are a critical component of that, and partnering with them is critical.
Thank you. So I saw a bunch of hands go, but Ellen is our boss today, so her hand is the one I really see.
Clearly what we're talking about is a multifaceted approach. But I want to take us back to the beginning. And Jerry, I'm going to you're the world traveler, want to bring you into this. When we talk about the cost of going to medical school, how much universities are charging, how much does that impact the outcome later on? When I'm hearing folks talk about, well, it costs $1 gazillion to go to med school. When I come out, I cannot work as a primary care physician for $250 or whatever thousand a year. So how do you impact without going back to the very beginning and the amount of money that universities, which, and again, 60s liberal, I'm just going to say this, are so incredibly endowed that in perpetuity, they could probably drop their tuition in half. But Jerry, what about other countries where the healthcare costs are not as high as ours are? How do they deal, or do you know, with how they train their medical personnel in the cost of medical school?
I'll try to answer that, but let me first say, I think it was the first President Bush that had that comment about 1,000 points of light. Am I recalling that correctly? I'd like to say that and say what we have here is 1,000 points of issues that we need to resolve here, one of which you just brought up, and we probably brought up 40 or 50 of them in the course of the last hour and a half. In other countries, physicians are not paid anywhere close to what they're paid in the U.S. So you have the AMA, it's my opinion now, I've got a couple of physicians sitting in front of me here, so I'm not sure whether they would agree with me or not, but the level of control of the AMA over medical schools, in my opinion, has caused what you've just described. I said earlier that I think we got to get the AMA, the feds, and the states together to subsidize training so that my son doesn't say to me 12 different times after I paid the tuition, I can't have a quality of life by going into primary care. The doctor here made that comment about, it is true, they have become, much like our school systems, we are taking responsibility in our school systems and in our primary care physician offices for all of what goes on in an individual's life. It's not just about healthcare. In other countries, that is not the case. I'm not saying that there isn't some of it there, but the educational systems and the public education systems and the healthcare national systems in those 5 other countries, in my experience, did not have that issue that they had to deal with because they built a system. We built a system that has been built on capitalism, which let me make it very clear, I'm a supporter of capitalism. However, it has gone amok, if you will, over the last 60 years because we've siloed so many elements, including the education of doctors.
Other panelists want to comment on this one? Let me bring up the topic of outcomes. So we've spent an hour and a half now talking about what is value-based payment, and here's how it's designed to work, and here's some of the problems that it will address. But I think it's worth spending a few minutes talking about, so how's it gone so far? What has been the impact both locally and nationally? So I'd ask each panelist to chime in on that, and I'll start with Chris.
I would say so far it's been pretty good. I wouldn't say great. I would say we're beginning to see a difference. When you look at metrics like breast screening, colonoscopy, several others, we see improvement. which is good, right? Back to some of the comments made earlier, people getting their screenings leads to better outcomes. And by the data, you can see that we are able to see improvements in that. More people are getting those types of services. And again, I believe that's because that's what we're paying for people to, providers to be able to look at someone holistically and make sure that their patients are getting what they need. They're asking those questions, they're directing their patients to get the type of care that they need. So I would say, so far so good. It's worth repeating what I said earlier though, we're in the very early stages and there's a lot more work to do.
Matt, what's your perspective?
Similar comments, I would probably grade us C plus to a B. Not to repeat as far as the screening, but I look at different programs like, one program we have is just on post-acute rehab. Working with the member to say, okay, are you better in a facility or do you want to go home with services? And bringing the member into that equation, just gets a member that recovers much quicker, has a say in the care they want to receive, and making sure we obviously supply that care, whether they're at a post-rehab facility or they're in their home. So a lot more to work on, but I think it's moving in the right direction.
Dr. Harbin?
Yeah, again, I'm coming from on the boots on the ground perspective. Again, I think it has been positive as far as really pushing small organizations to understand you got to build a bigger team, you got to build that data team, you got to look at the data so that you're informing your clinicians, your physicians, your NPs, your PAs, and their teams of what needs to be happening. We understood early on, years ago, again with Flippa, that we're not able to do that by ourselves. So several FQs got together to say, we gotta work with each other. We gotta help support each other. And we knew that behavioral health organizations needed to be part of that model. So for us, it's been positive because it kind of slapped us in the face with reality that we know this needs to happen, but we know we can't do it by ourselves. We know we're not being compensated to do this. As we build stronger by being larger, maybe we can have more voice in with MCOs to say, this is what we need if we truly want to keep people healthy and keep them out. So we're looking at the quality metrics. We're working with our clinicians. We have a data team, and we're one of the few, because who can afford a data team? But we know that's what we need to really look at the data to address the concerns. So it's positive as far as it's kind of a wake-up call several years ago to say these are the things we must do. It continues to be a struggle because you're not able to get compensated for the team that you need to build to do the work that you need to do.
Jen, what have been the outcomes?
Okay, outcomes. I say yes and no, depending on what segment you're looking at. Overall, CMS has put out these new models that really are trying to move our entire nation to more of a value-based approach. I think it's getting us focused there. I appreciate what you said earlier, Chris, about how here in Rochester, in our area, we really have a larger segment within some of these VBC programs than other areas of the country, and that has done really good things. So that's a yes in the outcome of moving us there. Higher quality care, absolutely. Screenings, standards of care for those with diabetes, those with heart disease, those with hypertension. So really, really good work in those areas. Good work in some of the cost reductions of getting people who are getting care at the emergency room who don't really need to be at the emergency room to other sites of service. Good outcomes there. There's still, then the flip side, the no part, there's still a long way to go of coordinating that care between the organizations that are represented here in this room with the providers who are actually seeing these patients on a day-to-day basis. So good outcomes, yes, still a ways to go.
Jerry?
So I'll take a little bit of a different tack. I'll be brief this time. From a personal perspective, as a 70-year-old baby boomer, I've consumed far more health care at Rochester Regional and U of R in this community over the last 10 years than I did in my previous 50. I think that can be said for most baby boomers. The last of the baby boomers turned 65 in 2029. We've got a major issue with respect to consumption of healthcare with respect to our generation. I've been very impressed with the services, the access to services, et cetera, and the quality of the services that I've received from both Rochester Regional and U of R. From a provider perspective, those folks that I advise as clients, the ability to both collaborate and compete at the same time when you're dealing with dollars is like solving a Rubik's Cube. So I believe that we've got to go through that process. I'm cautiously optimistic, not going to happen in my lifetime, but I'm optimistic that the journey that Jen referred to earlier, we will be accelerating, and we will be accelerating based on technology to a better solution than what we've been able to do over my 50-year career. Go ahead.
So we've got about 20 minutes left, and I saw a number of hands shoot up a moment ago, so we'd love to take questions from the audience.
Yes, hi, Catherine Bella with Flips. As it relates to outcomes, how are you evaluating outcomes from a health equity lens? So as you look at screenings and other well-known published outcomes, are you stratifying by health, by race, ethnicity, and perhaps also payer coverage?
I'll start with that one, because
Okay.
that is something that GRIPA, we have done. In taking a look, especially in the screening space, of where are our gaps? It's easy to look at them at the whole, but then trying to stratify them of, are there significant populations that are missing? And I think the biggest thing that stands out to me is, the answer is yes, but it's hard to get your arms around the data to be able to pull all that together, because the records are often incomplete as we try to pull all that data together to look at it. So if it's looking at a segment of ethnicity or of social status, of having that information at your fingertips to be able to stratify it, to know where your opportunities are. I think the clear answer is yes. You need to dig in deeper because there are those inequities that need to be focused on there. So that's my perspective from GRIPA.
Other panels?
Yes, I mean, yes, we are, and I'm sure MVP is doing the same thing, is to dig in and look at exactly by race, by ethnicity. I do like the fact, and touching a little bit on what Jen said, it seems to me that there's a greater acceptance now of asking those questions of patients when they come in, right, is to ask them about some of those social determinants. And patients aren't always excited about sharing that type of information. But the more information we can get will help us be able to drill down and target populations that are not getting the care that they need or the services that they need.
Okay, so a question at the middle table. Yes.
Yeah, Lenore Rose with Coordinating Care Services Inc. And my question add on to yours. May I just suggest that what you pay for, and someone up there said that, what you pay for is what you get. If we pay for equitable outcomes for all, especially for people of color, black and black out there, I think we'll get it. If we don't pay for it, we will not get it. You mentioned about paying for metrics and screenings, and you see better screenings. How about paying to ensure that we get the services that we so deserve?
Great. Any comment to that? Thank you for that. Certainly agree with that. No, I'm sorry. I thought, yes.
Yeah, and I just made Ann Wilder, president of CCSI, and I wanted to maybe piggyback on both Catherine and Laura's question. We're talking about outcomes, and Chris talking about your, sort of asking us, would we design the system today the way it is? And no. So our outcomes, I think it's health equity, but it's also thinking about what are the outcomes we most want. If we think about the 80% of health that really isn't health care, if we think about having payments follow the things that matter for people, I think it has to really, do with what are we looking at even as outcomes, and we want to be looking at the same things that we've looked at previously to build a system that is very different. So not necessarily a question, but just kind of an observation.
And just to add to that, and I think, Jess, you were talking about that, the data is important, and I know MVP's been in a lot of conversations just with Mark, just on data alone, and just the cost to invest to get that data. So how can we, as a payer, assist with giving you the reports to help you determine, okay, this is our population. What are they getting, through our agency, and where else are they going? So I think data is a big source of answering a lot of those questions. But as you stated, it's costly. It's not cheap.
Yes, question over here.
Sandy Frankel. I'm sorry that I came late, so I may have missed some of the discussion that you had earlier related to a couple of points I'd like to bring up. And just to give you a notion of where I come from, I'm the retired supervisor of the town of Brighton. But before that, I was a school board official and also a speech-language pathologist who worked at the Jordan Health Center. And so I have a variety of perspectives from that background. One area of concern that I have is maternal and infant mortality. I've heard today talk about diabetes, about a variety of different health issues, but we've got a younger population that is in desperate need of more care and how you get care to them timely so that they have good outcomes. So if I just raise that point. And then the other is, as you talk about the importance of having more dialogues, more conversations with stakeholders, I would encourage that you include government officials who have the ability to influence and perhaps actually affect change in funding for healthcare services, because if they're not in the conversation, they're not going to be informed and they're not going to make decisions beyond lobbying. So be a lobbyist.
Thank you for your comments. Any reaction from the panel?
Yeah, I love your call out to all the segments of our population, not just those chronic disease states, but those maternal, infant states as well that need attention. So I appreciate that.
Well, isn't it interesting, right? So I don't know how many people we have in the room, 50, 60 people, right? It seems like there's 50 or 60, they represent 50 or 60 different little pockets that they're focused on. And isn't that really what the challenge is how do we take care of all of those things all at the same time? And we can't heap it on all of our primary care providers to say, hey, you do it. It really takes joint effort. And I think data, as we've talked a little bit about today, is critically important to be able to identify those metrics, whether it's maternal, spinal, behavioral health, we mentioned several of them today, to really dig in and identify targeted populations and have actions and services to help improve the care, the health of those targeted populations. We can't treat it with a broad brush. We have to be more surgical and more targeted in our approach.
I see a question in the back. Renee?
And why do health insurance companies pay less for Medicaid populations?
Medicaid?
Yes.
Medicaid? Yeah.
Medicaid?
Medicaid.
I mean, it's the math of the premium dollars coming in from the state.
But then why can't you cross-subsidize from the cash cow of Medicare Advantage to help your Medicaid populations?
So
that's all what it will take.
Yeah.
That's what it will take, because the incentives and the access issues we're describing are driven by the reimbursement issues.
So
people don't take Medicaid, or providers aren't. That's funny because when you walk in the treatment room, the doctor doesn't care what your insurance is, right? The standard of care is the standard of care. With the insurance company and what they're going to pay the physician, patient to patient to patient, is wildly vary. And it's lower for Medicaid. They need more, and yet you reimburse less. When will our insurance companies stop managing their business in their line of business silos rather than and not cross-subsidize to support our more vulnerable populations that are part of this community that you as not-for-profit organizations are supposed to have a charge to serve?
Yeah. So Oh, go ahead.
No,
I'll actually clap for that too, and it's, you're gonna probably feel that that's a strange thing, right? Because you're kind of pointing at insurance companies and the way that they pay. Matt's exactly right? So we do get reimbursed from the state to provide that type of care, or payment for that type of care. We get paid from the federal government to provide Medicare type services. I would completely challenge your notion of the cash cow of Medicare Advantage plans, and we can talk a little bit more offline about that. And then employer groups generally are paying for commercial type insurance. Who do we go to say, hey, we need to subsidize this other line of business? Do we go to our employer groups? Are they interested in paying more, or are they interested in paying less than what they're paying today? They want to pay less, right? If you ask employer groups, if this was a room full of employer groups, they would be saying, hey, how can you lower my healthcare premiums? Why don't you subsidize from your other lines of business? If this was a room full of seniors, there are some seniors in this room, they would be saying, hey, how do you lower my premiums, and why don't you take the money from your other lines of business? At the end of the day, $1 is only $1. It can only be cut up and paid out up to $1. It's a challenge. It's a really difficult challenge. I can tell you with absolute certainty, it's not as easy as just saying, hey, take the dollars from another line of business and put it towards it.
Matt,
on the provider side,
Mark, let me just slip Matt.
Yeah,
Okay.
Sorry,
Mark.
the question. I mean, I hear what you're saying with that, but on the provider side, we do that every day. We are using our higher margin, and every provider in here, or they disenroll. So I was around when primary care started disenrolling from participating in Medicare because the rates dropped to a point that they were now non-participating providers. So providers do this every day. We see everybody we can see, but I could make a much bigger margin if I didn't take this population. I could make a better margin if I didn't take this population. So we're blending that every day. What I was wondering is how can we find a way for the payers to help blend that as well?
I think I want to add.
No, I just want to, I think that early on we have agreed that we're in a community where there's the will and to have serious conversation about how we can improve the health of this population. So we're not saying that it won't be difficult, but we're saying, I think what I heard from this young lady back there was the conversation needs to be had. And if there's a will, there's a way. And you know, boots on the ground, you take something from nothing, you steal from Peter, you pay him Paul, and try to figure out who the next Paul is, because, you know. So I think what I heard was, why don't we at least have that conversation needs to be had to see if there's a way.
Matt, you had a comment.
I think I just want to add to your comment that I think the payers are aware of that because we're in all products. I mean, we're challenged every day to be in a Medicaid managed care organization. It goes back, a couple comments made by Mark as far as a community and not-for-profit. You know, as an MVP and an Excellus, I mean, I'm just going to say, we don't want to see a United coming to town. We don't want to see an Aetna that might not get into a Medicaid managed care product. So we're doing it every day too, as far as balancing how do we offset, how are we able to still offer a Medicaid managed product. And going back to Jerry's stat, which I think is the most alarming, that 60 to 70% of the population is in a government-sponsored insurance plan. And for MVP, that's our biggest growth market that we have to recognize, and we have to be successful by working with you, the providers. So we acknowledge it too, and every day, we're taking that dollar and figuring out how do we slice it, but I think it's through conversations like this and value-based in the different levels, whether it's pay for performance or full capitation or rewarding for closing gaps in care, help us do that together.
Let me add to Matt's comment. Some of you may have seen in the New York State budget, which was just approved, you may have seen a couple line items that at face value look kind of surprising. Nursing homes got an increase of 7.5% in Medicaid rates. Hospitals got raises 5-6%. And one might look at that at the surface and go, oh my gosh, those are really big raises that are getting. But the background of that is there have not been increases, or there have been very small increases for a long, long time. And as we've been talking about here for the last 10 minutes, there's a lot of cross-subsidization of the government programs by the commercial market. And to Jerry's statistic of a few minutes ago, at a macro level, that's a big financial problem facing the healthcare system. We've got time, I think, for one final question. So who wants to cap off our session with an incredibly sage, thoughtful question?
No pressure.
No pressure. So if you stand up, it's got to be thoughtful and sage. All right, we have a volunteer.
Yes, Sarah Taylor of the BIPOC Parent Mental Health Project. Bring a different perspective serving in Rochester, Buffalo, and Syracuse. I'm sitting here listening to this conversation. I heard Chris, I heard Jamie, but partnering with parents, and I say this, how do we elevate the consumer experience in driving designs and models? My experience, we have these performative check-the-box advisory boards and consumer tables, but how do we really, from a physician perspective, healthcare perspective, payer perspective, begin to elevate the patient experience truly? Because if you ask me, the last 4 or 5 years navigating the behavioral health system, watching new models of care come out and RFPs come out, at not one time is the consumer experience elevated or even asked, in designing models, what would work for you? What was your experience? As I see the new psychiatric emergency rooms going up for pediatricians, pediatric services, not one time did the large healthcare organizations come to us and say, what was your experience navigating CPAPs or emergencies? So how can we truly, authentically elevate the patient experience and really get consumer advisory perspectives in these value-based models?
Thank you for your question.
I have to say it's a great question, but it's above my pay grade. I cannot give you a articulate answer to that question.
I also don't have a perfect solution for that, but ultimately, at the end of the day, I think it comes through listening. And I think that listening needs to come at the point of access through our providers when they're meeting with their patients, of listening and then being able to bring that feedback back so that we can work together to solve those problems. Because if we don't know what they are, you're right, we're not going to solve for them. We need to be listeners.
I will say that, again, I go back to Chris, who said the word we. We have to be inclusive of the community you serve. If you're designing and you're trying to make a change and you want this to happen, it have to be inclusive of the community you serve. So I just say it have to be a true we.
Matt, Chris?
I think that's right. I mean, I think we can't run out with solutions to problems we don't understand. We need to have dialogue and conversation about what folks want and what they need. That's an everyday part of what we try to do. Can we do it better? Probably. Whether it's on the payer side or the provider side, I think we can all do a better job of that. But you make a wonderful point. It's critically important to understand what people need before we try to solve it for them.
And then just to add, and again, Mark said we haven't had time to touch base on, it's just the data component and the fact we haven't even touched base on the new transparency rules coming out to let the consumer be educated. Why does it cost, for a chest x-ray, $200 here, but $50 here? you know. So I think a lot of the data and the transparency and being able to help the member, patient to get better educated.
I'd like to give a shout out to our coordinator of this entire event today, which is Ellen over here. So Ellen, thank you. Ellen or Will, do you want to?
And what an event it was. So we already gave the panel a round of applause. I think you should give yourselves a round of applause. You got some great questions, some great participation, right? Through events like this and conversations like this, I think we elevate the topic, right? Too often we have thoughts, we have concerns, but we don't talk about it. So to be a part of this, to have this type of discussion, to have this type of dialogue back and forth, I'm very excited as a consumer of where I see that we have the potential to go. So thank everyone for coming. Thank the panel. I want to thank the panel, which I already did. We're very grateful, like I said. We also want to give thank you to the staff at RCTV for getting here early to set up and film this forum. So I think we should give them a round of applause. Once edited, you will all receive the link as well as a link to the round table we filmed in April, which highlights the status of veterans health care in Monroe County. And with that, everyone have an excellent day. It's not golf weather yet, but it's coming. I have it on good authority next week we should be able to do that. Thank you all for coming. Have a good rest of your day.